All right, guys. Good evening. I think this is our second or third, no, second session of vascular occlusive disease. As you see, guys, this is a very common scenario. This will be like your main bread and butter cases when you go to practice. It's not the aortic, not the carotid. The reason why it's very important session because we're going to see on daily basis. And you can see that all cases will be very long because you have to take a lot of factors and make your decisions. It's not like aortic aneurysm, you just look at the size, not like carotid, you look at the stenosis. Usually in the peripheral vascular disease in lower extremity, you have to look at the age, the comorbidity, are we dealing with a wrist pain, colication, or tissue loss. Yeah, and you have a lot of things you have to look. That is why you're going to see the scenario is very long because they want to give you all the information, have you to make your decisions. Will not be like one line or two line. Anyway, let's go and start. Yahya, want to start?
Okay, Dr. Sam. Bismillah.
Let's go, bismillah.
75 years old woman present with sudden onset of severe lower back pain, bilateral leg weakness, and paresthesia 6 hours ago while she was having dinner. Her past medical history is significant for hypertension, hyperlipidemia, prior smoking, colon cancer, and recently diagnosed breast cancer, for which she is undergoing chemotherapy. She has no prior back surgeries or trauma. Her exam is significant for bilateral lower extremity paralysis and sensory loss. Both legs are cold to touch and femoral pulse are absent bilaterally. She has a midline laparotomy scar from prior right colectomy, a CT angiography with run-off demonstrate occlusion of the infrarenal abdominal aorta and bilateral common iliac arteries with significant circumferential calcification in the abdominal aorta and iliac arteries. There was no aneurysm or dissection demonstrated in the chest, abdomen, or pelvis. The patient is started on a heparin drip. What is the best approach for the management of this patient? This is
Okay.
75 years old with comorbidity, cancer, and active cancer, breast cancer, and history of colon cancer, present with acute lower limb ischemia, showed in the image, infrarenal total occlusion.
Okay. As I said, Yahya, you see, every step in the history, they got to tell you something to make your decision, okay? First is 75 years old, correct? So we're not dealing with a young patient, all right? Then they
Yes.
tell you she has paresthesia for 6 hours. So already you have a delay. You see, everyone has give you something to decide. Okay, so she already 6 hours ago. So she's a heavy, she has hyperlipidemia. She's a smoker, colon cancer, breast cancer. They want to tell you she's hypercoagulable, correct? They
Yes.
tell you she has bilateral extremity paralysis and sensory loss. What does that mean? That means you are dealing with a delay, ischemia, correct?
Yes.
Okay. Femoral pulse absent, there's nothing here. Midline laparotomy, right colectomy. So I'm going to tell you, look, it's not a benign abdomen, it's a hostile abdomen, correct? So this is of course what to tell you. CT scan showed occlusion of the infrarenal abdominal aorta, but bilateral common iliac artery, significant circumferential calcification in the abdominal aorta and iliac artery. So we're going to tell you it's not a normal artery. That means she has a disease in her artery before. Okay, you see how all this one? So you have to put them all together to make. It's not an aneurysm. It's not a dissections. So you can think about dissection or aneurysm. So that means you are dealing with a patient. She's 75 years old patient, present with a delay ischemia. She has a hostile abdomen. She's hypercoagulable, and she has a long history of vascular disease. Correct? This is what I get from all the history.
Yes.
So what the best treatment? So after you put all the things, then what the best treatment? Because there's a lot of treatment, really, you can do. But for this specific scenario, let's start one by one and see if it's fit or not. This is our first one.
A, bilateral femoral percutaneous access and the placement of Lysis catheters.
Do you think it's a good option for this patient?
It is delay limb ischemia, not.
Correct. So it's not good now time for lysis. Lysis take at least 24 hours, right? So you already have lower extremity paralysis and sensory loss. Okay. So this is not to be a good option because they put this sentence. So they will not be the right answer. Let's go to the next one.
Bilateral femoral percutaneous axis and mechanical thrombectomy. It is
Okay,
total infrarenal total occlusion with the aortoiliac calcified vessels, disease vessels.
I mean, disease vessel doesn't mean you cannot do percutaneous because thrombectomy or lysis, because when you do lysis, you dissolve the clot, then you see what the disease, and you can do endovascular. It's not a contraindication, but we said the lysis is a contraindication because it's already late ischemia. So if you put her on lysis, you have to wait for 24 to 48 hours, which we don't have it in this case. But somebody tell you, okay, well, let's do mechanical thrombectomy. Mechanical thrombectomy work right away. So this is a good option. But what the problem? You're dealing with aortic occlusion. Aortic occlusion is very difficult for mechanical thrombectomy to clean it up. It's good for like iliac, SFA, mobility, small artery, like 1 centimeters. But aorta, like 2.5 centimeters, you can't clean with a mechanical thrombectomy because, you know, mechanical thrombectomy is very small port. So really, mechanical thrombectomy is not good for aortic occlusion. It's good for like iliac occlusion, SFA, mobility, femoral, whatever, but not aorta. So in this case, even though it sounds like a reasonable option, but I don't think it's a good option because it's mechanical thrombectomy and you have aortic occlusions. The second thing, mechanical thrombectomy is usually big, and you have a lot of calcification. Sometimes it's very hard to replace it, you know, because it's a large device. It's not like a small device. So now this will not be a good option. Okay.
Yes.
Right?
C, aorto bifemoral bypass.
What do you think about this option?
For old age with a hostile abdomen, previous surgical history.
Right, it's not the best option. You see, when you have patient emergency, you're first not to do the best surgery. Always, guys, remember, I keep telling you that. When patient emergency, the best way to get him off his trouble. It's not the time to do the perfect surgery. Okay? Patient 75 years old, or delay ischemias, and has hostile abdomen. Because if you go through his abdomen, for some reason you injure his bowel, then he's stuck. You cannot put a graft. He has hostile abdomen, so a lot of bowel adhesion, especially has a right hemicolectomy. So if you injure the bowel during the procedure, it will be very hard for you to finish it. Then he's stuck. What are you going to do? Then you have to look for like bovine patch to repair it to make the tube, or you have to put rifampicin, suck the graft. So it'll be a lot of trouble. So we have hostile abdomen is not good for emergencies. So I will not be his best option. So 75 years old, all these issues, what kick him out of the table as soon as possible. You just do the axillobifin bypass, right?
Yes.
So this will be his best option. But I tell you what, the real life. This case came to me. Usually I go from both groin. Okay. I try first because I will lose nothing. I prepare for axillobifin, but I try first to do thrombectomy, open thrombectomy. Sometimes, most of the time, it's not going to work because the artery is diseased, but sometimes it may work. So I would try. If my frequency went up and I'm able to do thrombectomy, then do an angiogram and then an endovascular. Whatever I have to do, I do endovascular. If I can open only one side, like one iliac, I can like pass frequency one side, I cannot pass from other side, then I can clean up one side, do fem bypass. My frequency doesn't go up, I cannot clean it up, then I do like axillobifin. This is in practice, but in any exam, you just say I do axillobifin bypass.
Clear,
Right?
Dr. Sam.
All right. So when patient has an aortic occlusion like this patient, we're going to talk to her about what expecting mortality, morbidity. What do you think is her mortality will be? Because you have to tell her before surgery what kind of complication you can get from this kind of surgery. I mean, like mortality, we're going to tell her what her mortality would be, like 10%, 5%, 20%, 30%. You know, because you have to tell the patients, you know. Is about 20 to 30%. Okay. So you tell the patient you have a risk of, you know, mortality. So because aortic occlusion, it's not like a joke, you know, a patient 75 years old. So it's about 20 to 30%. Kidney injury is a problem. Could be, you know, kidney injury, respiratory problems, you know, Amputation is still a problem. You have to tell the patient, because even when you do this one, you end with amputation still. So you have to tell them the risk of amputation, maybe about 10%. You have to tell this patient about all this kind of risk before they get surgery. Any question from anyone?
Yes, Dr. Samer.
Yes, Bala.
Here in the scenario, they wrote lower extremity paralysis and sensory loss. This is considered Rutherford 3, irreversible ischemia.
Reversible, irreversible.
It is considered to, but with complete sensory loss and complete paralysis.
Malo complete. Why is it complete? Significant, they said. Well, this is massive complete. This is significant for bilateral lower extremity paralysis, sensory loss. Yeah, but it doesn't tell you it's complete or partial. You see, when they don't tell you, don't presume the worst. You know? If they want to tell you really it's like irreversible, they would say, no, it's complete sensory. Or motor function will be motor also. They say there's no motor function, you know. But then motor, and it didn't mention only paralysis. It's not like paralysis. So they didn't tell you that it's irreversible.
Okay, thank you.
Right, welcome. All right. Go to the next questions. Who was Sam? I want to take the question, Sama.
Yes, Dr. Samer.
Oh, it's a short one. We pass it. Okay, 17.
Okay.
What is that? Yeah.
17. Which of the following is not a risk factor for atherosclerosis Bluetooth syndrome?
Okay,
It's not
Bluetooth
risk.
syndrome. What is usually when we see Bluetooth syndrome? Usually it's what kind of emboli in كتبوا here, atheroemboli. So it's atheroma. It's not it's not a clot. The reason why anticoagulation will not work.
Will not work, yes. And all antiplatelets in office.
You give antiplatelets. What other option? HBO, hyperbaric oxygen, they work very well. Okay.
Oh.
So, but the main treatment is antiplatelets, and if you have HBO, I think they help. You know, with the Bluetooth syndrome. All right. So let's start with the risk factor.
Okay. Which of the following is not a risk factor for atherosclerosis Bluetooth syndrome? Older age. It is a risk factor. Abdominal aortic aneurysm. Formation of atheroma around the abdominal aortic can cause swelling to the extremities. Calcified fibrous arterial plaques. Actually, I saw the answer just now when you're putting the screen down.
Okay.
Yes, this is the answer. The elevated low density lipoprotein. And the last one, peripheral endovascular interventions.
Which one do you think the most common? We see it.
The most common, I think, peripheral endovascular intervention, or sorry, abdominal aortic aneurysm.
No, I think peripheral endovascular. I mean, how often you see aneurysm give you Bluetooth syndrome? Very, very rare. But peripheral intervention, and the second thing, that peripheral endovascular intervention is more common than aneurysm. You know, like every day, I'm sure like maybe 1,000 endovascular interventions done. So you're going to see it. And sometimes it's very bad. I saw a couple of cases, really, really bad, you know. I think peripheral endovascular intervention is the most common reason for Bluetooth syndrome these days, you know. Older age of the aortic aneurysms. Why elevated low density lipoproteins? Why is that can give you an emboli Bluetooth syndrome?
Because this show me that the patient has a hyperlipidemia and he has a risk of disease in his arteries.
Yeah, that means a disease artery atheroma. Yes. You know, because low density lipoproteins. You know, some people they go with what do you call it? The high density lipoprotein and low density. So you have to have a high low density and low high density lipoprotein to get an atheroma. So calcified, I see, even I don't know the answer. The moment they said fibrotic, you know, plaque, yeah, you know, it cannot be emboli because fibrotic plaque, correct?
Yes.
So even if you don't know the answer or didn't know how this works, but the moment you see fibrosis, that means it's very stable plaque, you know. And that is why we give a patient statin really to make it fibrotic, to make it, you know, more stable plaque. And this is the advantage of statins. If you have a plaque in the aorta, you know, there's always a high chance that you get emboli to the lower extremities. But
So,
usually
Dr.
it has to
Samer,
be with, yeah, go ahead.
yes, in just a case if I want to diagnose a Bluetooth syndrome and I want to look for the source, I did CT scan chest, abdomen, and pelvis, and saw there's a floating thrombus in the aorta. So I will start the patient on anticoagulation. What do you suggest to repeat the CT scan after 1 month to evaluation of this floating thrombus in the aorta, or?
First one, flooding thrombus will not give you Bluetooth syndrome, give you acute ischemia, the legs, the embolize, you know. Bluetooth syndrome is mostly an atheroma, so you're not going to see big clot in the aorta like floating thrombus. I don't think you can. You can see like a shaggy aorta, you know, disease aorta, atheroma in the whole aorta and iliac, sometimes femoral. So you're not going to see, again, a big floating clot. The second thing, the most important Bluetooth syndrome, you're going to have a normal flow to the legs. You're going to have a palpable pulses. Because if you don't have a palpable pulses, you don't get a Bluetooth syndrome. Because if you have an occlusion in the iliacs, in the tibials or popliteals, then the atheroma will stuck there, will not go down. You know? And really, you get atheroma from like popliteal or tibial down. Usually, it has to come from high flow from the aorta or iliacs. So the first thing when diagnosed Bluetooth syndrome, he has to have a palpable pulses. You know, the reason why we don't do a CAT scan. Do a CAT scan you don't do CAT scan to diagnose stenosis, but to find where the lesion. And the problem sometimes it's hard to tell because the whole aorta is shaggy aorta, so you don't know where he's embolizing from. Unless you see like a localized atheroma, if it's more than 4 millimeters protruding, then it's better to do a stent for that to stabilize it. You know. Again, treatment for Bluetooth syndrome is antiplatelets and high dose statin. You have to give high dose statin to stabilize the plaque. And again, if you have an HPO, you can add HPO for that. If you back to your question, if you see floating clot in the aorta, again, I'll be concerned more about acute ischemia and Bluetooth syndrome. But anyway, if you decide to treat it medically, no, usually 2 weeks. 1 month is too far. Usually 2 weeks will be the CAT scan, and you get an idea how is it getting larger, smaller. So usually will be the CT scan, CT angiogram in 2 weeks.
Okay, thank you.
Any other question? All right. Let's go to third question. Now we go to Barak.
Yes, Dr. Sam. A 68-year-old man present to your office 1 week after left lower extremity angiogram and superficial femoral artery stent placement with pain and discoloration in his left first through fifth toes. The patient doesn't have any thoracic or abdominal aortic aneurysm based on the prior CT scan. He is on aspirin 81 mg daily, Plavix 75, and atorvastatin 10 mg daily. His vitals are as the follow. His pulse is 81, blood pressure is 130/85, temperature is 98.8, and pulse oximetry is 97% on the room air. On exam, he has a palpable left dorsalis pedis pulse and triphasic waveform on the left dorsalis pedis and posterior tibial artery. The distal portion of the toes has a distal discoloration and is sensitive to light touch. The ABI is 1.1 bilaterally, and toe pressure on the left could not be obtained due to pain. What is the next step in the management of this condition?
Okay, this is the way how it looks. What do you think he has?
This one may be Bluetooth syndrome.
It is a Bluetooth syndrome, yes. Why you are confused? You see, it's like all dots. See here, the end, all the toes, you know. And the second, they give you all the reason to think about Bluetooth syndrome. Oh, sure, he has left lower extremity angiogram, so he has interventions. Okay, we just mentioned that. He has a palpable left dorsalis artery. Okay, so he has palpable pulses, so he's not an ischemic to think about ischemia. Okay, he's very sensitive to light touch. It's very important. See, it's very, very painful, by the way. Bluetooth syndrome is very, very painful. It's worse than rest pain. It's very painful. And you cannot help them, just pain medication and antiplatelets. But it's very, very sensitive, you know. EBI is normal, so it's not an occlusion to think about maybe ischemia or popliteal artery occlusion or popliteal artery occlusion or something like that. So he tells you that everything is normal, so the intervention was successful, but the problem here was the Bluetooth syndrome. Okay?
Yes.
He already on aspirin and Plavix. So what are you going to do for this patient?
I will increase the dose of atorvastatin.
Yeah. See? Yeah, you're right. It's only at 10 milligram, right? So
Yes.
we just have to go higher with dose to 20 or sometimes go to 80, right? You mentioned that last time, or 40. All right, so let's see what the options they said here.
Right lower extremity diagnostic angiogram. No need. Anticoagulation.
This will make it worse, right? Because he already
Yes.
has emboli from angiogram, so you do another angiogram, it will be worse, you know. So this will not be a good options, yeah. All right, emboli it could be from a stent placement, right? Not for the intervention itself, because they put stent. When they put a stent, if you have like a soft plaque, this will squeeze it, and all this trash will go down to the toes, and end with the Bluetooth syndrome. Okay, next one.
Anticoagulation. Also no need.
Oh, okay.
Increasing atorvastatin to 80 milligram daily. This is the correct one.
Okay.
And CT angiography, no need. Sympathectomy, also no need.
Okay. Some people they say they do sympathectomy, but I think this should be a history for Bluetooth syndrome because they thought this will dilate the arteries, so will relieve the pain. But again, I don't think anybody does it anymore. So your best treatment again, antiplatelets, increase statins, and HBO if you have it. Any question about Bluetooth syndrome? Like 2 questions about that? Any other questions? All right, going fast today. That's good. All right, let's go to the next one. Here. Yeah.
Yes, Dr. Samer. A 36 years old white woman present with several months of left calf claudication with hicking and walking up inclines. She has a past medical history of varicose vein and past surgical surgeries include an appendectomy. She is a non-smoker and ride-share driver by profession. On exam, she has palpable pedal pulses bilaterally, no pulsatile mass are in the abdomen, groin, or behind the knee. Her ankle API are 1.16 on the right with triphasic waveform and 1.14 on the left with triphasic waveform. Her exercise API are shown in the figure, which the following differential diagnosis is not likely in this patient.
Okay. First, it's not likely. It's not good in the exam. I don't think they do that now, at least in the state. They should not give you not likely because it's confusing for people. But I don't know, here you may get these questions, but not likely or not all except they don't like this. They want to give you what is the best answer. Anyway, so which one is likely? Let's see first about the exercise book. What happened? This is the blue one is breaker. The red is ankle. Right ankle. This is the left ankle, the green, and this is a brachial. So what happened? This is before and after exercise, okay? It's before and after 1 minute. In the right side, the ABI almost like the same or went a bit up, more than 1. On the left, the ABI went down to 1, and after like 5 minutes, went almost back to the normal, almost. It's not like, but became like normal. So that means the rest ABI is normal, but exercise ABI is abnormal. Okay?
Yes.
So we go back to questions. So 36 years old. So we talk about young people, young woman, and she has left claudications, hiking, walking, but everything is normal. Exam is normal, pulse is normal, ABI is normal, but she has a positive exercise drop in the hair ABI. Exercise ABI, drop in her treadmill test with a drop in the ABI and went back to normal after 5 minutes. Okay. So the question is that what are the scenario the young people can give you this kind? Of course, it's not an atherosclerotic for sure. So what are the differential diagnoses? You want to go through them or you want to guess by yourself?
The rest
What do
of
you think in young people? What disease we can think in young people?
entrapment.
Yeah, this is the first thing you think about popliteal entrapment syndrome, correct?
Mm.
What else? Second one. You see it in the wall of the popliteal artery. It's very rare. Maybe I saw only one case in all my life.
Cystic.
Yeah, cystic fibro. What called it? Cystic adventitia disease. Adventitial disease. Okay. This is the two most common yearly. You can read about it, but popliteal is the most common, and then the cystic adventitial disease. Okay. Less common, you can see what we called it in the persistent sciatic artery. I just saw one case here in Saudi, which has persistent sciatic artery. You know what persistent sciatic artery? Yahya?
Continuation of femoral.
There's no femoral. So what happened is the external become
continuation of
internal, and then from the external go from the popliteal arch, from the popliteal, obturator fossa, go through it. So when you feel a pulse, which has no femoral pulse because no femoral artery. You see, this is a congenital. Even though he has a distal normal pulses, but there's no femoral pulse because his artery goes through the obturator canal. You know, it's like it's go with the is the area where the sciatic nerve goes. The reason why it's called persistent sciatic artery. So this is the one. So let's see what options they gave us. Let's go one by one.
A, popliteal entrapment syndrome.
Okay, could be possible. They want not. Okay, again. They want what's not likely. Okay?
Not likely.
So this one. So this is good.
Yeah, cystic adventitial disease can be caused.
Okay.
Iliac endofibrosis.
You know what's that? Very rare.
No.
Forget about it. If you don't know, let's skip it. Okay, next.
Berger disease.
Okay. And last one.
Persistent sciatic artery.
Okay. Let's talk about Berger disease. What's the Berger disease?
Peripheral vascular disease with patient history of heavy smoker.
Okay. You think the ABI will be normal or abnormal?
No.
Berger disease?
No.
Abnormal, right? He has ischemic like wrist pain, and he has severe, tapering of the tibial artery, right? And you can see like a corkscrew collaterals, right? You see, this is a sign of Berger disease. You don't see tibial artery, you just see corkscrew collaterals. This is a Berger disease. So ABI would be abnormal. So in this scenario, it cannot be a Berger disease, correct? So even if you don't know what the iliac endofibrosis, cystic is very, cystic, popliteal, which one? This one. Persistent sciatic. So for sure, it's not a Berger disease, okay? Iliac endofibrosis is happening with the people who cycle, but this is who cycles a lot. Like you go to marathon and everything. It's very rare. I never really saw any case in my life, but you may read it sometimes if you go through textbook. So this will be confusing for you. But when you see Berger disease, I think it's very obvious it is a problem here. It's the wrong one. But iliac endofibrosis, it can give you a similar picture because of like stenosis become iliac because of the cycling and continuous bending of the external iliac artery. It's a very rare condition. All right. Any questions?
Thank you.
No question? All right. So let's keep going. It's good today. There's not many questions. Let's go to here. We go back to Sama, right?
Yes.
By the way, where is Abdullah? Is he on vacation?
Yes, doctor.
Yeah, he's a I didn't see you again. Okay, Abdullah. Here we are. Take this question.
Okay. So a 27-year-old healthy man presents to the vascular clinic with bilateral lower extremity claudication, presenting as pain in the bilateral calf after jogging around 200 meters. along with some coldness and paresthesia in the bilateral feet that resolve with the rest. He has no other significant medical history, prior surgery, or family history of any vasculitis. On examination, he has palpable femoral and pedal pulses bilaterally. What is the next step narrowing the diagnosis of his condition?
Okay, so this question very similar to the one before. 27 years old, healthy man with codifications, and his physical exam is normal. So that means here you're going to have one of the above what we talk about it, right? He may have one of these above, right? Let's go back.
Yes.
He may have polyteal, cystic, iliac endofibrossis, peristaltic artery, right? We
Yes.
just talk about. So how are we
Yes.
going to make this diagnosis? Is that question they ask you now? So if you think about this for diagnosis, how are we going to narrow it to the right questions, answers? Let's go one by one.
Okay. A, resting ankle brachial index. No.
No, because it's normal.
B,
Why?
yeah.
Well, we have to know why. Abdullah.
Because it is normal. Yes. Yeah. Exercise ABI alone. No. We should يعني have it in rest than exercise or provocative.
No, exercise ABI will tell us that is a problem. Yes. So exercise, if you do exercise ABI, the ABI will drop. But the problem,
Yeah.
it cannot tell you which one of these four, right? So it's not really
Right.
very helpful. Yes, you tell me. I'm not sure I will order it, but still I have to order something else to know which one of these four this patient has.
Yeah.
Okay.
C, ABI in the stress position with the plantar and dorsiflexion of the foot. Yes, this one can differentiate between the diagnoses.
So if
D,
this one positive, which one will be?
popliteal entrapment
Correct.
syndrome.
Correct. Okay.
D, MRA of bilateral lower extremities. No. Actually, it
cannot
can
say-
give. Yeah, it can.
Yeah. So why is it said no? So which one is C or D? Well, let's go to the last one.
Diagnostic angiography of bilateral lower extremities.
Think that will help diagnostic?
No.
No, we have a CT angiogram, right?
Yeah.
You can do a CT
Oh.
angiogram. The second thing, he has above pulses, so the angiogram will not help unless if you do it in dorsiflexion and plantar.
Yeah.
You know, so should do an MRI or ABI. So both is answer. So how you decide? Then you go back to the question. Go to the
Yes.
question. What is the question?
They want to. Which one can narrow the diagnosis of his condition?
No, before.
He has claudication.
No. What's the question? What is the
What is the next step?
next
Okay.
stop? Next.
Okay.
You see?
Yeah.
Not
So
only
I
what
will
the
go
best,
with ABI.
they tell you what the best
first.
test. As I said, what the best test are goes MRI. MRI is
Yeah.
much better. It can give you the anatomy and everything. But you're not
Yes.
gonna do MRI and put them like in $2,000 test and they come negative, you know. So I will do first something simple. I just do an exercise test, ABI in a stress position, and then if it's positive, I should for MRI. So again, you have to be careful what you read the question, So what is the next step? Next step to do an ABI. Okay.
Yes, sure.
So how you do this ABI?
And
Plantar will be
dorsi and plantar flexion of the foot.
Okay, because you strength which muscle? Because you want to tighten up which muscle?
Gastromenius. The medial head of gastromenius muscle.
But how you do? How is the plantar and dorsiflexion? Because the muscle work only in one. You cannot. We don't have muscle work in two opposite movement, right? I mean, you cannot have one muscle do plantar and dorsiflexion. So why just they give you two?
To compare.
Question. No, but if you do plantar, you can get the positive. If you do dorsiflexion, you get the positive.
I don't know, Sarah. What I know,
because plantar it should be an active. You do it by yourself, so you stretch your muscle. You see what I do? So it has to be an active plantar, flexion. You see? So you do active. When you do an active, you stretch your muscle. The gastrocnemius. Dorsiflexion should be passive. If you do active, then you're not stretching the muscle. But if you do passive dorsiflexion, then you stretch the gastrocnemius. So active plantar flexion and passive dorsiflexion. Okay.
Okay.
Yeah, this is the way. That is why they both work in this one passive, one active. So both you can move the muscle either by active or passive movement. So let's talk about Trabant syndrome. I'm sure you guys get question Trabant syndrome. This is the most common. They love this, Trabant syndrome in all exams. So you have to know how many types we have in Trabant syndrome. You remember them, or you have to go and read about them, guys?
5 types we have.
Okay, some people say 4, some people say 5, some people say 6 even. But
Yeah.
let's start. Tell me what the most common. What is? You remember what's the types, or
Yeah.
different remember? Okay, what's type 1?
Type 1, the artery is abnormally medial to the gastrocnemius
Correct.
muscle.
Correct. Type
Um,
2.
Type 2, the medial head abnormally inserted lateral.
Correct. Type 3.
Um,
Oh, that's good. You're studying. That's good. Type 3.
This is accessory slip gastrocnemius.
إلا إذا كان جوجل قدامك عم تطلع عليه. Go ahead.
لا لا والله.
Okay, go ahead.
Type 4 compression
Oh, type
by
3. What is type 3?
accessory slip of gastrocnemius.
Slip. You're right.
Yeah.
Sorry. And type 4.
Popliteus muscle هي اللي عاملة compression.
That's correct. So what's 5? You said 5. What is the 5?
إذا كان الفين compressed with the artery, it's considered 5.
Wow, this is very good. Very impressed. Number 6.
It is functional, what I know.
Wow, that's good. That's good. That's true. Now, most of us, we know only 4, but 5 and 6 is just right. As one is vein and artery, one is functional. But usually we have the main 4 in a 4 anatomical variation can give you a Trabant syndrome. And what's the treatment?
Treatment depend if there is يعني arterial damage or not. If there is no arterial damage, only release the head of gastrocnemius muscle. That's enough, most likely.
You
But
mean
if
you
there
cut
is,
it? You mean not release? You mean you cut it? Okay.
yeah.
What
But
is the
if there is
approach?
either you mean it depends on the type. لما
All of the same.
we can do medial and posterior approach both, but depend on the type of popliteal therapy.
As far as I know, the posterior, but how you can do medial? Medial is very high. How can you cut the gastrocnemius if you go medial? You have to go posterior approach.
Okay.
Right? Unless you read somewhere, but I just cannot imagine how can get medial to it. Unless you're going to do a bypass without releasing it. Like if patient has a occlusion or whatever, but always we go posterior for the Trabant syndrome. We cut the head and release the artery. If the artery is damaged, you can do a patch or you can do intervention, vein and graft, depending how bad is the artery damaged. I think that's all right. Yeah. Any question about Trabant syndrome?
Hello, Dr. Samer.
Yes, please.
Yeah, what about duplex study for diagnosis?
Yeah, you can do it, but yes, you can do it, but you have to do it in stress position because in normal position you see nothing, But
With with the plantar and dorsiflexion.
Yes, you can do it with that. And then you can see the compression, the signals will go down, But always people they start EBR even simpler. And this is the reason why he didn't give it to you. Here's ultrasound because it could be an option, yes.
Okay, thank you.
Yeah, it's a good option. Any other question? All right, let's keep going. We go back. I got lost. Who's next now?
I will take next question, Dr. Samer.
All right, let's take it. Let's see what's the question. Here we are. So this is type 1, as you said. This is when go medial. Type 2 said we have the muscle. This is when you have a slip. And number 4, we have a popliteus muscle. So that's all. All right. Go ahead.
Okay, 62-year-old man present to the vascular clinic with 3 months of bilateral hip and calf claudication at 50 years. The patient has a history of hypertension, hyperlipidemia, and coronary artery disease with myocardial infarction 5 years ago. He had bilateral femoral endarterectomy and iliac stenting 2 years ago for wrist pain in the right lower extremity and claudication at a short distance of 20 yards in the left lower extremity. He had complete relief of his symptoms after his last operation. He quit smoking 10 years ago and walks daily, now limited by claudication. He's on aspirin, carvedilol, lisinopril, and statin. His ABI is 0.55 on the right and 0.53 on the left, with toe pressure 35 and 34 respectively. His diagnostic angiogram is shown in the figure, which of the following is true regarding the management of claudication in this patient with suprainguinal disease?
All right, so let's go through here. So what do you see?
We see, I see external iliac stenosis, both sides, more on the right side.
Okay, so stenosis here has a stent. They were able to stent on both sides, right? Let me see. He has iliac stent. He has bilateral femoral and iliac stenting. Yeah, I didn't say where, but it looks like it's a stent here, and there's a stent here. So you have a stenosis here. You have a stenosis here. Femoral looks. What else you see here? What's the problem with this picture? What do you don't see? The internal iliac, right? Both is gone. I don't see internal iliac. So I don't know if it's a disease or they're covered by a stent. Maybe they use a cover stent. I don't know. Okay, so we look at this picture. I see stenosis here, bilateral internal iliac occlusions. What else you see? Huge collaterals, right? You see that? Coming from the distal aorta. Okay?
Yes.
And why you have a big here? Because we don't have internal iliac. So it's a mean blood supply to the sigmoid, right? The IMA. Like this patient, guys, if you have to do like an aneurysm repair, I think you need to reimplant his because no internal iliac. So it's a blood supply from the sigmoid and rectum all coming from IMA. So I think you need to keep it open. This one's very important. If you close this one, you may end with sigmoid ischemia. All right, it's a very nice picture. Femoral artery are wide open, so we don't need any endarterectomy. So how you treat this patient, you think? What you should do? What you do? 62 with smoking. Let's go back to the scenario. 62.
Well, with bilateral hip
claudication. Hip because internal iliac are occluded.
Yes.
It's a life limiting, now limited by claudication. So the life is a limiting, okay? It's not like mild claudication. So that means
he need to be treated, yes.
Right, he's 62. And he did the intervention before he felt better because they opened his iliac artery.
Yes.
All right, so what would you do with this patient?
Maybe I will try a atherectomy while using Rotarix in this case because he has a instant stenosis.
So they in the vascular. You can try the vascular open. Put it this way. I'm going to do the vascular open.
For me, I will do it as endovascular.
Yeah, because as far, right?
Yes, as far as I know, claudicant, if we treat it as open, it will complicate things. So for me, I think I will go for endovascular approach.
It's not like complicated because it's like a localized lesion. If he has like the whole aorta and both iliac is occluded, no, I'll go with an open, But like this one is very simple. You just touch it, Why you should put him through aorta by fem where you can touch it with a balloon, drug-coated balloon. Yes, our intervention will be higher than open, but it is simple. You can repeat it, not a big deal. And you deal with the claudications. So I will just go and do endovascular.
Yes. And also in claudication, we need to treat only the influence.
You tell the patient that his claudication will improve, but his buttock claudication will not improve. You see, he has buttock, bilateral hip, hip and cuff. So the hip will not improve because
we closed both internal iliac, yes.
Yeah, but you tell him like if he has impotence, this will not improve. but you tell him your legs will improve, but your impotency or your hypercodication will not improve. So ahead of time, because sometimes patient he didn't tell you because he's shy. Maybe he came for the impotence. The reason why he wants a procedure, and the worst thing you do a procedure, they found he has still have impotency. So you have to ask him first, are you impotent? If he said yes, tell him, okay, I just let you know ahead of time. It's not improved. If you are here for this one. So some people I notice in the clinics, they mask it, that claudican, because they want to increase their sexual activities. And somebody told them because their tenial artery is occluded, so they want to do that. So just be specific with the patient. So when I see this picture, the first thing I ask him, how's your sexual life? He told me that is bad. I'll tell him, okay, don't expect it to get better. If his iliac are open, tell him no, you feel better. If his iliac occlusion and his iliac is open, then yes, they improve from endovascular. Okay, so let's go back to the question, see what they're asking. Let's start one by one.
Okay.
So they want to know what's the true, right? The second, what they want, what the true
Regarding the management of
what the
claudications.
true measurement. Okay.
Okay.
Let's go one by one.
Surgical aortobiphene bypass and hybrid femoral endarterectomy and batch angioplasty with iliac stenting have an equivalent 1 year patency. No, we're going to do it as an endovascular, so I don't think this is the right answer.
No, just a second. No, this side, Samer. They not ask you what you're going to do. They can give you a fact. Is this fact correct or not? You see? He didn't tell you what your next step. Look, and look at that. Yes. Look at the question. Again, the question is very important. He didn't tell you what your next step. He said, what's true regarding the management of claudication of this patient? What's true?
Yes.
It's not what is the best. It's not what the next. It's what's true. Is this statement is true or not? Okay?
Okay.
So let's go back to the question. Be careful. So what they're saying is
surgical...
that
So the aortobiphene and hybrid femoral endarterectomy batch angioplasty with iliac stenting have an equivalent 1 year patency. No, I didn't. The aortobiphene patency about 90 to 95 in the 5 years. So comparing to femoral endarterectomy and batch angioplasty, the stenting, I'm not sure. I think this is not the right answer. This is not the right statement. Sorry.
So surgical aortobiphene has better patency than hybrid or stenting. Correct. Primary patency, okay? If you look at secondary patency on limb salvage, is no different. You have to be careful. Only primary patency, because as I said, like these cases, you can do endovascular. You have to go second. Oh, let's go take first what we talked about last time. What's the difference between primary, assisted primary, and secondary?
Primary patency. Primary patency, the patency of central graft without any intervention. Primary assist.
When this will end? When you say primary patency, like for 1 year, what's that? That from the time you put the procedure, you did the procedure to the time for first intervention. This is the primary, correct?
Yes.
So the timing from first intervention, either surgical or endovascular, to the second intervention, which is endovascular or open, because sometimes maybe you have to go a patch, is a primary patency, correct?
Yes.
Secondary patency starts from second intervention until what? Primary assisted primary. What's assisted primary?
Stenosis pre-intervention to the time of the
assisted primary. We have a primary when you have you did a case, iliac or aortobiphene. He came after 2 years with a stenosis, which required intervention, correct? So that means primary patency is 2 years. You go and do a stenting, okay? Then it open for 2 more years. Then your assisted primary is from the first until you finish your intervention. Maybe do like 2 or 3 intervention, okay?
Okay.
Secondary patency, it's from the time you put it until when?
First intervention, yes.
It's the primary assistant. Until occlusion, okay? Until intervention until occlude. When occluded, then you finish. So anything before that, we consider secondary patency. You follow it or not?
Yes.
So primary patency without any intervention, assisted primary to the first intervention, secondary patency all the way up until the occlusion. You can do multiple intervention until occlusion. When you occlude, then your secondary patency is finished. Okay. So anyway, let's go to the next question.
Okay, the B, pressure measurement across a hemodynamically significant iliac lesion is 5
millimeter. This is
Yes.
very important. Guys, when you scrub with me, you see sometimes I measure the pressure through the stenosis. And as you can, so when we consider significant drop, means when you see stenosis, you put your catheter, like you have an iliac stenosis, you put the catheter above it and you pull it down. You can see the pressure will be the same or drop. If it doesn't drop, that means good. It may drop 2 or 3 to 5. This is significant or not. When you're going to say, oh, this is stenosis is significant, I need to fix it. Usually it's more than 10. Okay, 10 milligram, 10 millimercury. So if I put my catheter in the water and have iliac stenosis, I'm not sure if it's significant or not. So I put my catheter in the water. Like let's say the water, the pressure is 110. I put it down to the external iliac. If the external iliac is like 105, so only 5 millimercury is not significant. But if I put it in the iliac and the pressure in the iliac like 90, more than 10, then it's significant. Then I have to fix it. So any drop or in the pressure more than 10 millimeter mercury is considered significant. Okay. And we do that a lot when we, when we do like iliac occlusion or stenosis, want to be sure it's successful or not. Whereas we ask the patient to come up we compare the pressure between the aorta and the iliac after stenting to see if it's successful. Because sometimes you have a stenosis and you don't see the angiogram, because remember, angiogram is 2D. You see only AP. You don't see lateral. If you take your C-arm and do lateral, sometimes the stenosis, you don't see it on AP. That's why it's very important to measure the pressure. So after I finish, when I do an iliac or aortoiliac or syrup technique, when I finish, always I compare the pressure in the femoral sheath with the radial sheath. If I don't see a difference, I know successful intervention. But if the radial artery gives me like 120 and the angiogram after like syrup looks perfect, but in the femoral sheath, my pressure is 90, I know I'm missing something. Then I have to go and figure out and see where's the problem. If you don't do measuring the pressure, especially when you do with aortoiliac, you end with the early stenosis and occlusion. All right, let's go to the next one.
C, a covered endovascular reconstruction of the aortic bifurcation technique is the preferred approach for this patient.
You know what syrup, right?
Yes.
Yeah, syrup is to put a big stent in the aorta and both in the iliac, right?
Yes.
So in this patient, you don't need aorta looks beautiful. So I need to put there. I mean, you are dealing with the external iliac 2 region here. So I have to go and put big stent here, 2 stent here. It doesn't make sense, right?
Yes.
And the second thing is the most important to see with the syrup technique, see what the name is a covered. So a covered endovascular is an ablation for syrup. It's a covered. So you can put a covered stent, okay? And
You
look at
close
this,
the collaterals.
this one, the big collateral. So if you put a syrup in this patient, you include this collateral, it will be a big disaster, especially internal iliac is occluded. If internal iliac is not occluded, then it's okay. Because what happened, like sometimes you have aortic occlusion like from here, because you see like under the branch, and iliac occlusion here. So I want to do a syrup technique because aortic occlusion was both iliac. But I have a big collateral here. So what usually I do syrup, but I do uncover stent here. I put uncover stent here, and then I put 2 cover or uncover stent here. So you can do syrup without with uncover stent, but we don't call it syrup at that time because the name will not fit. But it is a syrup technique, So this is not a good in this patient. Let's say the last one.
D, an endovascular or hybrid approach has a higher reintervention rate relative to aortobifem surgery.
Yeah, that's true.
Could be
right?
Yes.
Yeah, because in the vascular, we just mentioned that aortobifem, it's better patency, primary patency.
Yes.
But in the endovascular or hybrid, they have, just secondary patency are the same, but the primary assisted patency is higher. So you have more intervention with endovascular than with open repair. But if you look at secondary patency, it's the same. Limb salvage are the same. So if you get this question, primary patency is weaker for endo and approach, but secondary patency and limb salvage are the same between endovascular and open. Okay?
Okay.
And the same for survival also, mortality. All right, let's go back to you, Baba. Any question, guys? Please stop me at any time. Okay.
Excuse me,
Which of
Dr.
the following?
Yes, now it's a question here. Go ahead.
I didn't get the difference between primary and secondary and assessed primary patency. Can you
Okay, no problem.
please
Okay, yes, we can say that again.
repeat
Yeah,
it again?
right. Like you do aortic biphim, okay? And after like 1 year, it has a not occlusion, stenosis, okay? So you need to balloon it, okay? So you balloon it and go for 1 more year, okay? Then, so your primary patency is from the first time you did the stent or surgery to the first intervention. This is your primary patency, okay? Secondary patency is a patency where you do interventions and the stent is still open. After 2 years, stent is still open, but you did like 3 interventions. This is still called primary assistant patency. But the stent is still open, but you did like 2 or 3 interventions. Okay?
Okay.
So after 3 years, stent is still
Yes.
open, but I did 2 interventions. So it's not my primary, it's primary assistant patency. Okay? Yeah.
Okay.
So you keep doing intervention, but after 5 years, the graft has included. You did couple intervention included. Okay. So
Okay.
now, from the primary to the get occluded, this is my secondary patency. When get occluded, خلاص, this is my secondary patency. From the time I start to the time is occluded, this is my secondary patency.
Okay, I get it. Thank you.
Okay. So this is the difference between primary and assistant. Yeah. All right. Next one. Para.
Dr. Samer. Which of the following is true regarding aortoiliac occlusive disease? Lerish syndrome is characterized by palpable femoral pulse and bilateral calf claudication. No.
Correct. Yeah.
Aortoiliac occlusive disease doesn't present as a chronic limb-threatening ischemia. Also wrong.
Because it can come, right? It can come anyway.
Yes.
So what kind of different presentation to aortoiliac occlusive disease?
It can present as acute limb ischemia. It can present as a chronic limb ischemia or critical limb-threatening ischemia.
Or
asymptomatic if they have good collateral.
Yeah, or asymptomatic. So it's big range for aortoiliac disease. Could be complete asymptomatic. Even if you have aortic occlusion, you can complete asymptomatic if you have good collaterals. Could be just claudicant, right? Or could be chronic limb ischemia. So you have different stage depending how much collateral, how bad the occlusion disease. So you have a different scenario for aortoiliac occlusive disease. Okay, see?
Yes. The systemic collateral pathways in aortoiliac occlusive disease include lumbar, intercostal, deep circumflex iliac, internal thoracic, inferior epigastric, and obturator arteries. This one may be correct.
Okay, let's go next one.
Renal or mesenteric arterial involvement sufficient to warrant concurrent repair is seen in half of patients with aortoiliac occlusive disease. No, it is much less.
Much less, right? So we do a lot for aortoiliac disease, right? Iliac stent, aortic stent. How often we do with renal or mesenteric? It's very rare.
Very rare.
Okay. So this it's wrong. So even if you don't know C is right, because all of them is wrong, so C it should be the correct, and usually it's come from it's correct. They have systemic, they come from the collateral, from the costal, circumflex, epigastric, or curators. All this we call them the systemic collaterals. What other collaterals they have?
From the inferior mesenteric to the internal iliac?
Yeah, that's what we saw it now here, like this one. We just saw in the picture before. This one, see? IMA can give you a good collaterals down to the lower extremities, especially if you have aortic occlusion here. You see a lot of time. You see aortic occlusion here. You see large MA, IMA give you all collaterals down to the pelvics and then to the internal iliac down to the lower extremities. So we have two types of collateral to low extremity from aortic occlusive disease. As a systemic, we mentioned them before, like lumbar, intercostals, what we mentioned also. These circumflex, general thoracic, general epigastric, obturator arteries. And then you have a visceral, which is usually come from the inferior mesenteric, which is come from superior mesenteric. Superior mesenteric give to the inferior mesenteric, because usually it's occlusions. If you have occlusion at the level of the renals, you know, then the collateral will comes from, if the occlusion above the IMA, then the collateral comes from the SMA to IMA. Through what,
Yes.
you know, what the collateral called?
Arc of Rayulan.
That's correct. And what the other one called?
Artery of Dormont.
That's good. That's good. All right. Any question about this one?
No,
Yeah,
thank you.
A scenario. Yeah, take next one. It's a simple one. Let's give you next one. You like some
Okay.
scenario? Oh, it's not a scenario. It's okay. Go and take it.
Okay, which of the following is true for endovascular versus open surgery for infrainguinal chronic limb-threatening ischemia?
All right. So I think this is a very important question. There's two trials, right? There's two trials talk about endovascular versus open for infrainguinal. What's the name of these two trials?
Basel trial,
Basel 1 or 2?
Basel 2.
All right. This is the update. You have Basel 1, but this is Basel 2. Okay. And
BEST CLI.
trial. Guys, you have to read about this trial, please, for the exam, because this is a most common trial. It's very, I'm sure people love to ask you a question about it, so you have to know about it, okay? So let's summarize very quick. BEST CLI trial, what they said. What their conclusion? We're going to go through the trial and all the things, you know, what their conclusion, BEST CLI trial. Which one is better, endovascular or open?
I think both conclude open is better.
No, not both conclude. No, they're against each other. That's why they hate each other. No, they have different conclusion. Exactly the opposite.
Basel conclude open is better than endovascular. Good quality vein and
open CLI. Is they CLI or Basel?
ماني فاكر والله.
Don't play lottery, okay? أنا كويس في الحظ. Just kidding. No, BEST CLI is, they said, BEST CLI, there is no, first come BEST CLI trial, and showed that if you have a good saphenous vein, surgery is better than endovascular. Okay? So this is where the first one came, and we are so happy. Everyone, you know, intervention, they were so upset because, you know, in Basel 1, we know that endovascular always the first approach is better, but BEST CLI trial showed no. If you have, but you have to have a good vein. So the first, if you have a good saphenous vein, then bypass is much better than endovascular. If you don't have a vein, saphenous vein, then endovascular should be first. Don't go to the arm. Don't go like artificial. Don't go like cryo vein. Don't do like synthetic vein. Don't do like patch, Miller patch, all the things. No. They said then endovascular becomes the best. So the first best treatment as limb salvage and for critical limb ischemia and wound healing is surgical bypass if you have a good saphenous vein. If you don't have good saphenous vein, then endovascular should be your second option. Basel 2, no, showed the opposite. They still showed that endovascular treatment as a first strategy, they have a better endpoint of major amputation and death, less death and major amputation than if you do surgery first. So this is really the two different, so really this is not, you know, solved, but I can tell you what you can conclude from these two stages. It's a similar in kind of way that both agree endovascular is the best first approach for below the knee or infrainguinal, but if you have a good vein, no, surgery is the best, which makes sense. But if you don't have a vein, don't struggle and go to the arm or do like spiral vein or go like with a graft or with like a Miller patch. No. Go to endovascular. Is it clear, guys?
Yes.
Okay. I just summarized, but you have to go and go more details because they may ask you, you know, about endpoint, you know, what's primary endpoint, secondary endpoint, you know, how much the patency is better, which is the patency or is the mortality is different, is limb salvage or amputation is different. So you make it out of questions. So just go and read the summary about base CLI and basal. But the most two different first that base CLI said surgery should be first, endovascular should be secondary. Basal 2 said no, endovascular should be first, and surgery should be the second. Okay.
Okay.
Then we go to basal. Basal 1, what also they have like a secondary endpoint. They look at the success limb salvage after, if you do surgery after failed endovascular, are the same or not. And they found that if you do surgery after endovascular, then your limb salvage is worse than if you do it as a primary surgery. This is basal from the main basal trial, basal 1. Okay.
Okay.
Okay. Again, amputation. Okay. So they found that because, and the reason why it makes sense, because if you had endovascular first, most of you, that's what happened most of the time. You already destroy your distal artery. Like you have a nice popliteal artery, you can do nice fem pop, maybe above knee or below the knee. If you do endovascular, you put a stent, most probably popliteal will be destroyed, so you have to go further. So the limb salvage will be worse than if you do primary first, surgical first. Okay. All right, let's go back to the questions.
So option A, prior ipsilateral endovascular intervention has a negative influence on subsequent bypass. This is basal 1.
Yes, and this is what they said, yes. And now this is everyone agree on that if you have an endovascular intervention first, and you have to do bypass later on, the bypass, like I give you an example, okay? You have SFA with your occlusion and you have single run off, which is through like posterior artery, right? So if you go and do you can do very nice fem to posterior artery bypass with the vein. If you have a good vein, which is best CLI trial, you get excellent outcome. But if you're going to play with this endovascular and put a stent in the SFA popliteal and ballooning the popliteal artery, posterior artery, when all this be thrombosed, because when you go to send to surgery, when all this thrombose is sent to surgery, then you already lost your posterior tibia, or maybe you only have small segment, or it's already dissected, or it's very small or full of clot. Then your bypass will not be as good as you did from the beginning. So this is the whole idea from this question, that if you have any prior endovascular interventions, then subsequent surgery will be worse. But this does not mean that you have to do surgery first. You see, even basal 1, they said that, but they went to basal 2, they didn't say, no, you should do surgery first. No, they still want to do endovascular, but this is just a fact, like a secondary endpoint. They found that if you have to do surgery, which is rarely we do already surgery after endovascular, because now endovascular becomes so good that I even felt always you have something to save it and do it again and again and again, but in general, if you think what the message you have to get from all this one, which I do in my practice, that if you think that patient endovascular will not last long, then don't waste your time in endovascular. Go to surgery from the beginning because you have better outcome. I give you an example. Patient have SFA and popliteal occlusion, both artery occlusion, and you have single run off. Yes, you can do endovascular. Yes, you can open it. But how long will last? Will not last long because it's popliteal artery and SFA is occlusion, single run off. You can put a stent like metal jack from all the way down. It's not going to work. It may work like for 2 months, 3 months, 6 months, going to fail. So this patient, don't waste your time with endovascular. Take him right away to the surgery. He has a nice posterior tibial, do femdistal bypass to be beautiful. But patient come with like short SFA occlusion, a nice popliteal sleeve as a run off. You're not going to send him for surgery. Why you need the surgery? You can be very nice with stenting or just ballooning or drug-coated balloon or atherectomy, and you're done with that. So you see, so you have to use post-trial where's the best for the patient, So this is what the post-trial want to tell you, that if you think that endovascular is not going to work, don't waste your time, do surgery right away because you have better outcome. If you think that bypass endovascular is good and quick and you can good result, then do endovascular. Any question?
Okay. No.
All right, let's continue with that.
B spliced vein bypass is superior to endovascular approach for preventing major adverse limb event or death for infrainguinal critical limb threatening ischemia? No.
This is best CLI trial. They should know. As I said,
Yes.
you need a good saphenous vein, not arm vein, not you know. I mean, different. Unless if you're dealing with an infection, it's a different story. If I have like an infection and I have to do surgery and then have a vein, I may go to the arm. But patient just for critical limb ischemia, good saphenous vein or endovascular. Okay.
Yes. C. Wound ischemia and foot infection Wi-Fi stage 1. Patient benefit from open versus endovascular revascularization for CLTI.
Why? No, it's not. It's not like an
Wi-Fi
advanced
1
wound
is not ischemic.
Yeah.
Is not.
It's not ischemic, so it should not open. It's not like a late ischemia. So most of it's a localized lesion. So I would say no.
D. Patient with the CLTI who require an infrapopliteal revascularization should be considered for best open treatment first revascularization strategy.
But yeah, should be considered for best
this
open
one-
treatment. What do you think?
This one go with the basal 2.
No, didn't tell you saphenous vein. They mentioned it. They mentioned it here. No, basal 2. Basal 2, yes. It doesn't go with best CLI. Right. No, but you can say for the best open, this best open talk about best CLI, right?
Yes.
Because best CLI is not about saying open should be first.
Open first. Yes.
Basal 2 said in the vascular first. So here talk about best open. Okay?
Yes.
But what the problem? Why make this sentence wrong? Because they didn't say you have a good vein. Okay? So the stereo same sentence. Patient with CLI who require infrapopliteal vascular should be considered for best open treatment for the vascular strategy. If he has a good, saphenous vein, then become correct.
Yes.
But they didn't mention it, then no, you cannot take it like, because they put a very important, they said you have to have a good saphenous vein. This was very important part of the trial. Okay?
So I think A is the correct answer.
Is the correct answer, yeah. These are good questions. A lot of things to, lots of questions can come from this, But please go and read Basel 1, Basel 2, and BCLI trial. Any question, guys, about this?
It is clear.
Okay, it's getting late. Let's keep going. Maybe one or two more questions. We're going back to Yahya. You still awake?
Yes, Dr. Samer.
All right, let's go.
Which of the following is true for the surgical revascularization of aortoiliac occlusive disease? A. In patient with bilateral occluded external iliac artery and end-to-end aortic anastomosis is the preferred approach. The wrong answer, the not right answer. The end-to-end aortic anastomosis used only in not aortic occlusive disease, only in the aneurysmal aorta.
No. This is not true statement. No, relax. I mean, this is very old. I know. I never thought they'd ask this question again. When I was in training, they used to give this question a lot. They were like, when you do aortobiFEM, should do end-to-end or end-to-side. Always showed end-to-end is better hemodynamic than better end-to-side, So this was a concept at that time. You have to do end-to-end if you do aortobiFEM because best hemodynamic than end-to-side. But you don't do it when you have bilateral external iliac artery occlusion. You know why?
Not do end-to-end?
Yeah. You see, because as I'm saying, it's a very old question. Because that days we used to do aortobiFEM for external artery occlusion only. There's no endovascular, right? So the aorta and common iliac and internal iliac are open. Okay. So if you do end-to-end, you get the flow to the femoral, but there's no flow to the internal iliac because external artery is occluded. So in this scenario, you have to do end-to-side because you want to keep the flow down to the internal through the aorta and both common iliac artery. You follow me? What I'm saying, this question came from the eras who was not the vascular, because nobody now do aortic bypass for occluded external iliac artery only, right? I mean, if you external iliac artery occluded, I mean, also you can do stenting, ballooning, whatever. I mean, really, I can see aortic bypass for occluded external. But anyway, if you have it, and nowadays we don't do end-to-end for aortic occlusion, and the reason why, yes, we know hemodynamic is better, but technically it's more difficult because aorta is disease. And imagine you cut it, and then you have to anastomose end to end. If you had any trouble, like suture start breaking down, aorta start coming down because aorta is calcified or fragiles or have a lot of atheroma, then you're stuck because end to end you committed. So really, we don't do end to end anymore. Always end to side, because I can make the hole as long as possible, because aorta could be small. I need a big graft, and end to end you cannot do that. Where end to side you can do the graft you want, the size you want. So I don't think anybody do end to end anastomosis anymore. As you said, for aneurysm we do end to end. For aortic bypass occlusive disease we do our end to side. But this question is a whole lot different from this question, so I think it's a very bad question, this one. And I'm surprised they still have it now. At these days, they come with the same question. But this is the reason why they want to tell you that you cannot do end to end, because if the external is occluded, you want to give flow to the internal, so you have to do end to side. So it's a bad question. So the next one.
An end-to-side aortic anastomosis is advisable in patient with large inferior mesenteric artery or important accessory renal artery.
Yeah, the same thing, because when you do end to side, you want the blood flow to the internal inferior mesentery. If you have big inferior mesentery, the same concept,
Yes.
Okay.
The limbs of an aortofemoral bypass are tunneled bluntly over the ureter. No.
You do above or below the ureter? When you do aorta by fem.
Above.
Well, you above the ureter or below? Above. Like if you do aorta by fem, you want to tunnel your graft. You tunnel it above or below the ureters? First below,
Above.
because if you do above it, you can to close the ureter, right? So the reason why when you tunnel that, I always tell you guys, you have to keep your hand exactly at the external iliac artery, because the ureter closes the aortic bifurcations and very attached to the artery. So if you don't really put your finger, you're tunneling exactly at the artery, you can pass it above the ureter. And then if you do bypass above the ureters, then the bypass will compress the ureter and with a hydronephrosis. Okay? The reason why it's very important when you tunnel, you have to see the ureter and be sure you are behind the ureters. All right? Is it clear?
Clear.
One time I did the case, and after I finished, I found I am above the ureter. What do you do? This happened with me one time. So what do we do now?
Urology opinion and digesting.
Sorry?
Digesting of the ureter by the urology or?
No, why you need to stent the ureter? This is something permanent, so you can keep a stent there forever.
Cut the limb and tunneled.
Yeah, and there's a graft. That's exactly what I did. It's a graft. It's not a big deal. You can cut out the anastomosis. It's a big deal. So I cut the limb, I pass on the ureter, and then suture it back again. But just tell you how it's important to have to look. So always when I do aorta by fem, I look at the end. It's very important, because if you do it above it and end hydronephrosis, it's a disaster. Then I don't know how you can. Then you have to put a stent, and a stent has to stay there, and they may affect your kidney function. It's a problem. So please, guys, and the only way to avoid that, by passing your finger, you're tunneling, feeding the artery in the back of your finger. Always you have to feed the artery back of your finger. So you are passing exactly at the artery. And even when you pass it, mobilize it and be sure, look at the ureter, find the ureter and be sure you are above the, because it's very easy, you can pass above it. All right, next one.
An aortic occlusion extending to the level of the renal arteries requires supraceliac control and clamping.
Do you think so? Do we have to do supraceliac control and clamping?
Extending
you
to
see,
the
when
level.
we
Yeah, if reach to the renal,
Mm-hmm.
but not suprarenal, supraceliac.
I
Clamp.
mean supraceliac. You need to go supraceliac or suprarenal? Suprarenal, right? Why you have to go
Suprarenal, not supraceliac.
Yeah, so this is wrong. Right?
Yes.
Oh, so the right answer is, which one was? B.
B.
Okay, right? Yeah.
B.
So anyway, so for when we have an aortic occlusion, yes, we put suprarenal, but we don't clamp it. You see, I was mentioned that. You dissect the renal above, you dissect the aorta above and below the renal. And you put two clamp, one above the renal, one below the renal, but you don't clamp it. You open the aorta about 2 centimeters below the renals without clamping above the renal, because you want the blood flush to push the clot out. Because if you clamp suprarenal and start cleaning the artery from inside, it's very easy to push the clot to the renal artery. So two things first you do. First, you put a vessel loop around the renal because you don't want any embolization to the renal because the flush occlusion, the clot is very close to the renal. And then you open the aorta without clamping suprarenals. When you open the aorta, starting the clot, suddenly you see the blood will flush in your face because the moment you take the clot out, and all the small debris will come out. When you see the blood flushing in your face, then you apply the suprarenal clamp. Then you look inside the aorta, you look at the renal orifice, be sure there's no clot went there. You release your vessel loop to be sure you have good back bleeding. After that, I move my clamp to infrarenal, clamp it, and then I took the suprarenal off, and then I finish my aorta biphasic. So this is the step you should deal with the flush occlusion of the aorta at the level of the renal. All right, it's been like an hour and a half. Any question, guys?
Thank you, Dr. Samer.
All right, should we stop now? Do next week?
Okay,
Okay.
Dr. Samer. Thank you.
All right. So we stop at this one, 25. Do next week. Thank you very much, everyone.
Thank you.
Any question before we leave? Anybody has a question? No question. All
Thank
right,
you.
guys. Thank you very much.
Thank you, Dr. Samer.
Take care. Bye.
Thank you, Dr. Samer.
Thank you.
You're welcome.